Excellent point. I mean, MRGPRX2, it's a G-coupled protein cell receptor, and clearly we've done our genetic, this was not in urticaria, it was in atopic eczema, psoriasis, and itch of idiopathic in monkeys that had old age itch and what we call chronic pruritus of undetermined origin. In all of these diseases, the common denominator was overexpression of MRGPRX2, which was highly correlated to the itch intensity.
Hello, everybody. It's another episode of our podcast from the UK network, the Galen Global Allergy and Asthma Excellence Network, subnetwork for Urticaria, Urticaria for you. And I'm here, me, Torsten Zuberbier, president of Galen, professor here at Charité in Berlin. That's what's here. But I'm here on the internet together with my friend and colleague, Gil Yosipovitch. And Gil, if you want to introduce yourself, please.
Well, first of all, thank you, Torsten. It's a pleasure to be here. Yes, I'm a professor of dermatology and director of the Miami Itch Center at the Dr. Philip Frost Department of Dermatology. And also, we are a UCare center.
Which I'm truly happy about. And actually, I need to visit you sometime in the near future. And it's across the Atlantic. But Miami, you said, is not that far away, if I remember correctly.
Perfect. Usually in the cold winters of Berlin, it's nice to go and visit sunny Miami.
That's the idea, but actually I'll be there for several days in August. So maybe you find a date. But Jill, for our audience now, it's actually important to talk about itch. Itch in urticaria. And itch sometimes, well, everybody knows itch can drive you crazy, to be colloquial, but itch can also be really, people get suicidal thoughts sometimes. Do you want to elaborate a bit more from your knowledge?
I dedicated my career to itch. It's part of my name, but I would say that acute itch, all of us are exposed to somewhat, but chronic itch really is a major health problem. The majority of patients with inflammatory skin disease, and clearly urticaria, suffer from it. And I agree, in extreme cases it can cause suicide, but depression, anxiety, stress are kind of intervened with this problem. And the majority of the patients with chronic itch have also sleep abnormalities due to the itch, because there's a lot of nocturnal itch. And I think that we better understand in the last 2 decades that historically, we always focused on histaminergic itch, which in chronic itch is not, even in urticaria and chronic urticaria, we've bombarded our patients with chronic urticaria for many years with mega doses of antihistamines, but still we didn't solve all the itch of these patients. Some patients respond quite well, but I would say around 40% of the patients didn't respond to the antihistamines. So clear is that we know now that the majority of chronic itch is non-histaminergic, and therefore we have advanced our understanding, and we're still learning. There's type 2 inflammation, the immune system is involved, there are neural interaction, and clearly the mast cell, the cell that is the cornerstone of urticaria, has a major role in many types of chronic itch due to its fact that, when we studied in medical school, everyone knows what neurogenic inflammation is. And it actually has a significant impact on chronic itch. And therefore, it's an exciting time to better understand how we can treat these patients.
Jill, I think we should now unravel it a little bit more for our people listening outside. I can tell you a story. You mentioned the high-dose antihistamines, which was a good step forward in the 90s. But I also did some research on pseudo-allergic food, much being laughed at later by my American friends. Now there's a turnaround, and we've discovered the so-called X2 receptor, MRGPRX2 receptor, which we can show that in vitro, even with ingredients in pseudologin-rich food, can be activated on skin mast cell. So I think you said histaminergic itch, and the X2 receptor is one of the receptors for non-histaminergic itch. What do you say? In urticaria, how many patients should rather go into that direction? What do you say?
Excellent point. I mean, MRGPRX2, it's a G-coupled protein cell receptor, and clearly we've done our genetic, this was not in urticaria, it was in atopic eczema, psoriasis, and itch of idiopathic in monkeys that had old age itch and what we call chronic pruritus of undetermined origin. In all of these diseases, the common denominator was overexpression of MRGPRX2, which was highly correlated to the itch intensity. I'm a big proponent that MRGPRX2 targeting it would be an unbelievable good treatment. There are developments in this area. Unfortunately, one of the drugs had some issues, but I want to inform my colleagues in the industry not to forget about this target, because I think it's one of the most important inhibitors of mast cell role in itch. And I agree with you, it's not just on pseudoallergic. I think in drug reactions, targeting it will reduce it. It would have an impact on so many conditions that are itchy. Hopefully there will be additional work in that field. I can say that there's some recent data. We've always were asking if this MRGPRX2 is only expressed on mast cells, but there is some data now to suggest that it's also on nerve fibers. And again, it amplifies how significant the importance of this receptor in itch pathways.
Yeah, actually, it's great. So we speak in the same language. We should encourage companies to go into that direction. And luckily, we are in a situation now that many companies show interest, startup companies, and I'm hopeful. I'm hopeful there. But also maybe I can share with you some unpublished experimental data. We can show that some ingredients in food can, some patients, increase the expression of X2 receptor on mast cells. So it's very fascinating. And we've got so many patients who say there can be different factors in urticaria modulating, not maybe being the cause, but modulating the activity of the disease, modulating the itch. But we also have people who do not have urticaria and still say they get itch in certain situations with certain food. I have one question. Pain and itch have some similarities, but some differences. It's much easier to blend out pain if you want to go to sleep than itch. Why is that? Yeah.
So first of all, for years they were saying that you know, if you have itch, it would inhibit pain, and if you have, pain, you won't have itch. That's totally incorrect. So there's a lot of overlap. First, let's say there are a lot of similarities. The nervous system that transmit itch and pain, very similar. It involves C nerve fibers mainly. It involves the lateral spinothalamic tract and somatosensory. Even we've done work on brain imaging, and you could see the same areas that are involved in itch get highlighted in pain and vice versa, although there are some unique features. So as you well know, pain never causes you to scratch. Itch is involved in scratching.
Sorry, Gil, not all itch. That's another curious thing. Itch in AD, atopic dermatitis, scratch, bloody. I've never seen a bloody urticaria patient. Maybe it's a bloody problem, but not a bloody patient.
You're perfectly right, but here's something, Torsten, that I'm not sure that I was always under the impression that patients with chronic urticaria do not enjoy scratching or do not scratch themselves. And we've shown before that the pleasurability of scratching an itch, there's a pleasure. I mean, patients tell you
endorphins, endorphins being released.
Yeah, and I thought that they actually don't enjoy scratching. But we've done a study with my colleague Pete Smith in Australia, who has he's another UCure.
Yeah, a good friend of ours, sure.
an unbelievable good physician scientist, and did 100 patients, and apparently they actually scratch and they enjoy scratching. The pleasurability of scratching an itch with them is similar actually to atopic. So here's what we think. I don't have, and we are trying to test that. I hope so. Hopefully we'll have that answer in a couple of years, is that they don't scratch as significantly as our atopic or other inflammatory skin.
What do you mean, significantly or deep? So they don't bleed?
That's a good question. I mean, significantly in causing lichenification, because you never see lichenification, you never see excoriation, rarely, you see that. So it's not that they don't scratch, but not deep. Yeah, I agree. I mean, we'll have to see it in more objective measures, but that kind of surprised me. So we all the time learn. I can say that it's an important aspect that differentiates urticaria patients from atopic.
Many urticaria patients also say that cold reduces their itchiness. They sleep colder. Is that something which would rather point at an X2 activation, or is X2 downregulated?
Not aware. It's an excellent question. I would think about cold with ion channels, the TRMP8 possibly that may, this is an interesting, so it won't be related to urticaria, what I'm going to tell you, but to the listeners, I hope that we have done work. A lot of times the literature says every cold is good for you to inhibit itch. So I can tell you this is totally wrong. There are diseases where, and this is how we learned from it, this is from our itch transcriptomic, and then we went in psoriatic patients, we found out that the itch correlates to expression of TRMP8, the receptor for cold, or the receptor for the old drug menthol, which activates that receptor. And I started asking my psoriatic patients whether cold helps them. And some said that it actually makes their itch worse. And then we looked at scalp itch in psoriatics, a major issue in psoriatics that is very itchy. And again, we've shown also not just on the genetic level, but also in expression on immunohistochemistry that there's overexpression of TRMP8 in these patients, suggesting that cold, when we generalize sometimes, I can tell you heat, there are hot showers could be very helpful. I don't recommend that because it can damage you and you can get burned, but hot showers sometimes help patients more than cold inhibition. So I think that a lot of times dogmas are easy to insert in textbooks, but you have to also question them. So clearly in urticaria, I didn't do studies on cold, but if it helps the patients, I do recommend. But if a patient tells you that cold shower makes his itch worse, listen to him because they know better than we do when they feel it. So always it's important to ask these questions. So I'm with you that it's fascinating.
I think, Gil, we need several messages now to our listeners. First, what you clearly see, these episodes, they are live. We don't rehearse. We have no idea what we say in the beginning, but we want to do something which is interesting for you sitting out there in your car or in your office and listening to us. First message is, and I think, Gil, that is a message you just mentioned, each patient can be different. We have to listen to each single patient. Dogmas is something which I don't like at all, neither in politics, nor in social life, nor in medicine. We should always be open-minded and look at positive things and, again, listen to the patient. I think it's pretty clear. We don't have the patient with atopic dermatitis. We don't have the patient with urticaria. We have individuals sitting in our office needing our help, and that is for me a big problem also in clinical trials. We often only look at the mean response. Often pharma companies neglect to see results that individual 100% responders are overlooked and not looked at subsets. So Gil, if you want to make a statement regarding the treatment, you said not everybody is in favor of an antihistamine. What would be your suggestion to differentiate between histaminergic and non-histaminergic itch? How long would you use an antihistamine?
Well, it's an excellent question. I mean, look, I quite am sure that if a antihistamine doesn't work and you go up to 4 times the dose of like cetirizine, you don't have to wait months. I mean, if it works, it works very quickly. The pharmacokinetics of this drug is very fast. The problem is always, with insurances, I don't know in Germany, but in the US, they always mandate you to, use for 3 months. Otherwise, we won't pay that. And it's ridiculous because these drugs should work fast.
Yeah.
If it
I
doesn't
fully
work,
agree.
I mean, why should you have to wait 3 months? So clearly, that's to me, an indicator that I rarely, I can tell you, I mean, I rarely want my patients to continue using a drug that, it doesn't make sense that always tell them, look, in
Thank
2
you,
weeks.
Jill. I knew that answer in advance, and I'm pretty happy you gave that answer. But to be a bit more interesting now, we talked about urticaria, but we also have atopic dermatitis network. What about a steroid has an effect on both histaminergic and non-histaminergic itch. What
Excellent.
about pimecrolimus, tacrolimus?
So they have antipyretic effect, but I am less inclined to use them because to me they're like a mild potency topical steroid. I don't see their role I've never given them for urticaria patients, but in atopic, 20 years ago when they were launched, everyone was excited. We won't need to use topical steroids. And I have to mention something that maybe would be surprising to you is topical steroid is a big invention in the dermatology field. And I still think that we'll use it in 50 years from now. It's just that it covers so many aspects. And if you use it correctly and not overuse it with high potency steroids, it should be in our shelf of treatments.
Well, it's natural, by the way. It's one of the natural ingredients in the body, steroid. So I agree with you there. But then we move to the next step, which is also in trials for urticaria. What about JAK? We've got topical JAK inhibitors. Do they act on both pathways of itch?
Excellent. Yeah, they do. They're actually very effective. Again, because the way that JAK cover not just one cytokine or one pathway, they do an effect both on non-histaminergic and histaminergic itch. So the bottom line is that yes, steroids topically or systemically, they would work. I can tell you, I was surprised. This has not been published, so I have to be careful. But we did a large analysis with a drug company on large databases, and I don't know in Europe, but in the US, it really surprised me how many chronic urticaria patients are using systemic steroids for long periods of time. It's just unbelievable. It's an easy fix. So doctors in the community say, hey, I'll give you and you won't have the hives, but the implications on long term.
But you've got moony face, Cushing syndrome all over.
But I'm speaking about we looked at the comorbidities. It's the hypertension that goes up. It's eye issues, cardiometabolic.
Yeah, we agree. Gil, we agree. That's not a good idea.
A vascular necrosis. All the bad things. So I'm just saying, I'm very hopeful this is a really exciting era that the pharma found out that urticaria is the new kind of target for the industry. So I'm thinking the next 5 years, our chronic urticaria patients will face a renaissance of treatments. And it's just, I'm so excited about it this year.
Jill, that would be nearly a closing remark. But I want to challenge you with one more question. So we've got our guidelines, we've got the treatment, it's antihistamines, high dose, omalizumab, potentially cyclosporin A, upcoming remibrutinib, dupilumab in the licensing. What about the current urticaria patient? Do you sometimes add on drugs like gabapentin, which are really itch modulating drugs? I personally do that in some cases, also in AD. In some cases, I add it on. What do you do?
So first of all, just the correction, dupilumab already is approved in the US. I know it's not in
It
Europe.
is. Okay, yes, sorry.
So,
That is
and
for
also
that side
in
of the
Japan.
Atlantic.
So that's already something good for the listeners. Not so easy to get it still, but it makes a big difference. So let's go back to your question. Yes, I do use GABAergic drug. I do SNRI like mirtazapine that we publish, and I'll explain why. There is some phenomena in chronic itch patients where the nervous system is overactivated. I've published that, and I, for years, kind of lectured about that the nervous system is overactivated, and therefore you want to dampen a bit, reduce that overactivity, and the only drugs that can do that on the neural part are using GABAergic drugs and SNRI like mirtazapine. So this is an option. Clearly, it's in my treatment armamentarium. And yes, they have more side effects than just an antihistamine, but
it's an option. So to close for our listeners, what you heard now is many good things. Go for the individual patient. Be hopeful and tell to your patients a lot is coming up. But if you want to go not the beaten track, but go side tracks and look at what individual patients, you can contact the nearest UCare center and discuss your patient. And then maybe you'll end up with a totally different approach in that individual patient, but go that way. And with that, I say thank you for listening. Thank you, Gil. Bye-bye from my side. Gil, your last words?
Pleasure. Very excited about this era. We didn't even discuss about some of the drugs that can nuke the mast cells, c-KIT inhibitors. So it's so an active area of...
That means we have to meet again in another episode of this podcast, and everybody needs to stay tuned in. Okay, good closing remark. Thank you. Bye-bye, everybody. Bye.